Hey guys, welcome back to The Pathway. I'm Taylor Henrik. I'm here with Sarang Patel.
Hey guys.
Hey, so today we're going to be diving into a topic. We're going to talk about PTSD. We're going to talk about the basics and the not so basic. I'm excited to dive into this topic. I always like to bring something interesting to the table, as do you, and I think this is a good one to talk about. Today we're going to dive in on PTSD. We're going to talk about the basics, we're going to talk about criteria, diagnosis, and then let's talk about some things that are not so basic. Let's talk about things that our clients and our listeners would be engaged with. Does that sound good?
Yeah, cool with that.
All right. So let's start at the basis, okay? DSM-5 criteria, or just speaking about what leads to or how do you diagnose PTSD, post-traumatic stress disorder? Okay, Go ahead.
So I think less specific on the exact criteria behind it, right, which we're trying to talk about, or we can talk about too, right? You can dive into it. Is I think what a big issue that we see with PTSD, and this is part of our intakes we talk about with new patients. We always say, hey, we should look at and we should ask new patients what they're coming into the office for. If that makes sense, right? You and I have always talked about we shouldn't, because it gives you this tunnel vision. Because someone may not know they have trauma and say, well, I'm here for PTSD. So it's our job to say that anyone that comes to the door could have depression, anxiety, bipolar, whatever it could be, but also every single person could have a trauma. You have to rule it out, right? So we'll say, is trauma anything from, obviously you talk about physical, sexual, verbal abuse, fine, but it could also be anything that's ever been traumatic to their lives that they haven't noticed.
Correct. Witnessed trauma. Loss of a pet. Having to move all of a sudden for whatever reason. There's a plethora of traumas that are out there for clients that they suffer from.
Right.
Let me lay out very quickly a timeline, okay?
Yep.
Acute trauma occurs. Individual involved in motor vehicle accident for the sake of this example, okay? Within that first month, we've classified as acute stress reaction.
Right.
They are having vivid dreams or nightmares about the trauma, about the motor vehicle accident. They're avoiding driving or getting in a motor vehicle. They're having trouble leaving the home. They're isolating themselves. They're not sleeping well. They feel hypervigilant and jumpy, okay? From the 1 month mark to the 3 month mark, this would be classified as adjustment disorder. They're now beyond the period of where it's an acute stress reaction. They're now adjusting. We can't diagnose it yet based on the timeline, but they're trying to acclimate to the symptoms. There is still a significant impediment to their day-to-day activities, and they're experiencing all the same symptoms from that first month. When we reach the sustained or persistent period of 3 months, we now can classify this as acute post-traumatic stress disorder.
Right.
The symptoms are still persistent. It's causing activities of daily living issues, and they're suffering from the same symptom set. Whether an individual seeks care early on or later on, we can now make that diagnosis, right?
Right.
Okay.
Well done.
Thank you. I appreciate that. I feel really good about that.
You're like a walk-in chat GPT.
Wow. Thank you. Taylor APT, TPT. Not
Taylor
quite.
AI.
There you go. Taylor AI.
Oh, I get the TPT you're going
Yeah,
for.
yeah.
Taylor GPT.
TPT.
I got you.
So,
I see what you're going for.
what are some other symptoms? Just talking about PTSD, I really like where you started. I think it's important that we screen for it. Someone may not even identify it. They may not know that they have PTSD or may not suffer from a trauma. Unfortunately, a lot of times it's an abuse or some sort of offense that occurred when they were kids or in their adolescence or early adulthood. And so us being able to, as clinicians, identify that and then see how that might be informing their current condition is a skill. It takes time.
Yeah. It takes a lot of time. I think that sometimes you don't get it during the first evaluation or first visit. Maybe the client doesn't really realize that that's what the issue is. The patient doesn't realize it. So sometimes you have to re-ask the questions again later on, or you may find that, okay, yeah, this is actually traumatic. And they may say, hey, well, I didn't think it was a big deal, or I didn't really realize it was traumatic, and now I realize it is traumatic, right? Whether they've witnessed something, someone passing away, or whatever it is that initially like, yeah, it was kind of there, but through therapy and through visits, you kind of figure out like, oh yeah, that was actually traumatic to me.
Absolutely. For this diagnosis, I appreciate that you brought up therapy. I think psychotherapy is a big factor that can help with PTSD.
Right.
We're going to dive into this a little bit later, but your treatment methods or treatment options for PTSD are somewhat limited, and we're going to go into the not so basic in a little bit here. But off the bat, involving a psychotherapist who's informed or trauma informed can make a huge difference. Would you agree?
Yeah, I think I would almost argue that I don't think you can treat PTSD, official PTSD, properly without a proper therapist. I understand some people say, well, I have my friends, I have my parents, I have X, Y, and Z. And I get that. They can help you work through it. But I would argue that most of it, 90%, 80% of PTSD to be actually treated, you need a proper therapist that knows what they're doing. It doesn't mean they have to be trained in EMDR. Doesn't mean they have to do that. It doesn't mean they have to have a special certificate for trauma as well. But those who feel comfortable treating trauma, experienced with it as well, is a really important part about treating trauma because it turns into your interpersonal relationships with your family. It turns into how it could affect also your relationship with your friends, your workplace environment, your school environment if you're a kid or adult, obviously. So all these different avenues get affected by it. And then in turn, it bleeds into other things. Your PTSD uncontrolled without a proper therapist could affect your depression, could affect your anxiety. Again, I love talking about sleep all the time, but it could affect your sleep. It does affect your sleep. So then what we're doing is we're treating all these other avenues when realistically we need to treat the root cause of the problem, which is the trauma as well.
You got it. You got it. That's a very good way of seeing how PTSD can leach into other areas of psychiatry. So just laying it out very basic for our listeners today, what I like to screen for, and tell me if there's anything that you want to add or subtract. I ask about distressing memories from a past trauma, flashbacks, nightmares, night terrors, sleep paralysis, sleep disturbance in general. During the daytime, I look for restlessness, hyperarousal, hypervigilance, and avoidance. A lot of times you'll have avoidant behaviors, and it can look like anxiety. What are you avoiding? You're avoiding something specific, whether it be for some individuals, riding in a motor vehicle, whether it's I can't drive past a point where I have a bad memory, right? Like avoiding a road or avoiding a specific instance. Some people, I can't have a seatbelt on. There's a variety of things. One example that a client had that I worked with was like a choking episode, right? So the individual couldn't ever wear a tie and couldn't button up their shirt all the way because they felt as though it was exposing them to that, right? So it can just present in so many different ways. It's really an interesting diagnosis. And it's not just, I think the first thing when PTSD comes up is people think military or war trauma. Yeah. But PTSD is not just relating to that. No, of course, that's a very vivid example. Yeah, definitely. But PTSD affects so many different populations.
Yeah. I think we've talked about maybe before too, is the triggering event, right? And the hardest part about psychiatry or working in psychiatry, I think comes into play, is everyone's trigger is different. The same way everyone's trauma can be different. So what could be a minor thing, right, where someone's like, well, I feel like I choked on something like this, it wasn't a big deal. The next person, it could be a very big stressor, and that could be the traumatic experience. Or one car accident, which is, I think, common, or maybe it is for me because I'm a bad driver in that sense, is, or some would argue, is one accident may lead to a traumatic event where now it's like, that is my trauma, where I feel anxious to drive. I don't want to drive. I don't take my kids to school. I don't drive on the highway anymore because I got in one accident before, which you see kind of commonly, actually. Where some people could be like myself, could be like, no, it's fine. Any accidents keep kind of coming. It's not my trauma for me. So I think what we have to do is recognize that everyone's trauma or their trigger for what is traumatic for them can be different, including what may be mild to myself may be severe to you.
Absolutely.
Right? So
as the provider, you need empathy. Yeah, you need empathy, and you need to be understanding, and you need to be an active listener. We have to hear our client and understand what's going on for them. Sometimes they can't identify the trauma themselves. They don't know that was something that's causing an issue.
Right.
They may not identify it or even understand how it's affecting them today.
Yeah.
Like, is it bothering you? You lost a grandparent. Is that something that you think is informing your condition today? Like, are you doing better? Are you doing worse? Is that something that's still weighing heavily on you? Sometimes it's conscious, sometimes it's subconscious. You know what? When I think about it, like I've been thinking about them a lot. I miss them a lot, and I'm longing for them, Yeah. And it's causing me to not be able to sleep, or I'm not eating as much, right? So it's good to talk about some of the basic symptoms and how PTSD presents in our day-to-day individuals. We've probably both treated veterans before, and it's a little bit more vivid when it's wartime or they're downrange, whatever it might be, and they come back. Those are good examples as well. Yeah. And those individuals experience a very vivid level of PTSD in some cases. Yeah. Something that they have to really sort through. Extrapolating that onto us in the United States or just anywhere in the world, your day-to-day individuals who experience trauma, two different things, same kind of treatment method, right?
Right. Yeah, I think that it turns into we've talked about, hey, you need therapy, recommend therapy for sure with this, right? Someone who has trauma experience is obviously preferred in the situation. And we'll get into the future with EMDR, which hopefully we talked about, bringing on someone who can talk about that as well. But then it turns into what medication we want to use, right? We talked about it, how it bleeds into other diagnoses, anxiety, depression, mood control, sleep control, right? So I feel like what happens with PTSD, and there's no right or wrong answer, I would argue, in treating it. We may treat differently ourselves. There's obviously a lot more literature on it as well. Less options as far as what is indicated, if any, as far as what is actually indicated for PTSD treatment. But like we talk about in psychiatry, a lot of what we do is off-label compared to other specialties, right? So you say PTSD, let's talk about first thing, because it's my favorite, let's talk about sleep with it, right? So with it comes those nightmares. And I think with nightmares, it's important to realize how frequent they are. So you can't just ask someone, do you have nightmares? They'll either say yes because they had one this week and they say they had it happen last night and they're like, yeah, I have nightmares. You have to ask how frequent are they, right? Some days, most days, every day. How often do you have these nightmares? 1-2 times a week, every other week, a couple times a month? Because then you have to determine, is it distressful or not to treat it?
Correct. Is it distressing to the client?
Right.
How often and also how severe?
Right.
Is it you had a nightmare or a vivid dream about something that was not disconcerting to you? Or is it something that's recurrent based on a stressor or a trauma from the past and you wake up in a cold sweat? You wake up feeling panicked. It's interrupting your sleep multiple times a night.
Right.
What's the impact? And how does it affect you? Absolutely.
Yeah.
So something that we have to consider. And again, as we head into this next portion, so we kind of talked about the basics of post-traumatic stress disorder. I'd like to shift our conversation now to the not so basic. What are some of the conventional and unconventional treatment methods? And how do we treat PTSD? And as we do this, I want to note that this is not medical advice. This is our anecdotal experience, how we treat, because going back to what you said, our indications are limited, if any, for FDA approval. But let's be real. Let's be real with our listeners. Let's talk about how we like to approach this topic because we have so many clients that are affected by trauma.
Yeah. So you can definitely preface this is off-label, right? In the sense of obviously not what literature says maybe necessarily, but our clinical experience. Hundreds of patients, if not thousands of patients we've treated throughout the past that have PTSD, all of age ranges, young, adolescents, adults, right? Older adults as well, and any type of trauma. So one can argue that these are things that, hey, this is your guys' opinions. And I would say, yeah, they are from what we've seen that's worked. Well, we mentioned sleep. I think you have to treat your nightmares if you can. If it's distressful, we must treat it, right? Or we should try to treat it. And that may lead to some medication we talk about that are not necessarily psychiatric medications that work off-label to treat it, right? Whether it is Prazosin or Minipress, whatever you want to call it, that we may use for that, it may work, it may not work. And I tell clients it all the time. I'm like, hey, this could improve the amount of nightmares you have. The severity could decrease. The rate of improvement could decrease as well. The goal is for that to happen. However, we may not get there necessarily. So you have to kind of meet the client where they're at and say, hey, I argue and I always say, it might be wrong in this sense, but I say you have like a 60 to 70% chance of it maybe improving as far as nightmare wise. I can't guarantee you're gonna have no nightmares for sure, but this could help in that situation. I think a lot of patients actually see some improvement from it, but you have to kind of guide them in that direction. And then after that, after the nightmares, you have to say, what else do you want to treat? And I think we lead to antidepressants. We have atypicals that we may use. You and I both treat differently, which is totally fine as well, like we always say. But you kind of guide them onto things that are off-label because nothing is on-label necessarily.
Absolutely. Options are incredibly limited. And I know there's a lot of burgeoning science and there's a lot of studies going on in this space. We don't necessarily have to dive down any of those rabbit holes because none of it's substantiated yet. But at the core of PTSD, there's an anxious component.
Yep.
There's a depressive component. A lot of these symptoms are mimicked and shared. So we try to treat the symptoms, right? If you can't treat the disorder itself, you're going to help that client try to get to a stable baseline. And in doing so, you're going to try to relieve anxious symptoms, relieve depressive symptoms, maybe stabilize the mood. And like you said, maybe try to treat any underlying sleep disturbance. In cases where they have high levels of anxiety or it leads to panic, maybe you help them with rescue medications as well. But these are the options that we have available to us.
Right.
We are both firm proponents of EMDR and trauma-informed therapy. If it's not an EMDR specialist, then someone who knows how to help a client work through trauma, whether it's with case basis or it's with motivated therapy, whatever those modalities might be, we know that there's options out there that can help these clients get to a place where they're comfortable managing that root cause. And then you start to see progress. You start to see someone get over some of those distressing factors and have more ability to live the life they want to live.
Yeah. And I think as you treat trauma with therapy, right, you kind of tackle it. I always give the patient an example. It's like you're biting a piece of your trauma. You have to kind of digest it. You have to kind of swallow it, then you have to kind of digest it as well. So as you work through your trauma, everyone's a little bit different. You will have, or you can have spikes in your depression, in your anxiety, in your sleep, because you're, I always say with EMDR especially, or with however you're working with therapy, you're digesting that trauma. Mm-hmm. Sometimes I say it's better to treat it earlier than it is later, but not everyone fits this criteria in my opinion. Because sometimes the longer you kind of wait, the harder it is to kind of digest it a little bit, right? So it's harder to kind of tackle it. So I always tell people, especially with parents, say, I think the kid should see a therapist right now. I think you should kind of work through this right now versus waiting. Mm-hmm. But know that it can actually exacerbate certain diagnoses they may also have or symptoms they may have as well. And some of that's kind of normal.
You're exactly right. I've heard many a time my clients who are engaging in EMDR that it actually feels a little bit more intense off the bat. The adage of it gets worse before it gets better.
Yeah.
Because I think about it, your analogy of biting off a piece, I think about peeling off a scab, right?
Yeah.
It's the idea of like, man, it's kind of a fresh wound again, but I know it's going to heal.
Yeah.
It's going to take time, but we're going to get there. And I know right now it's going to be vivid. And absolutely, I see the same thing clinically, man. I see worsening anxiety, I see more depression, and I see sleep disturbance, but they understand like, hey, there's a process here.
Yeah.
My therapist has already spoken with me. I feel confident and comfortable. I've consented to this. I know that there's light at the end of this tunnel, and this is going to help me hopefully beat or conquer my past traumas.
Yeah. Well said.
Absolutely. Anything else when you think about treatment modalities? Anything else that you like to utilize? Anything else that you recommend to your clients who suffer from PTSD, whether with comorbid psychiatric disorders or just PTSD on its own?
Not that I think of. I'm probably forgetting something here, but I'd probably say that's pretty much typically what I recommend. I think once you tackle all this, it takes a long time, but I think you can't rush it. That's the other big thing too with trauma, with anything mental health related. Sometimes, you can't really rush the process.
Yeah.
So it takes time. It takes a lot of effort. Sometimes you have to change therapists. Sometimes you have to get a different prescriber's opinion on it as well. I think it's totally normal to do that. But yeah, you just can't rush this process.
One thing I'd like to add before we wrap today is reach out for help. There's a lot of groups out there. I've endorsed trying to find groups for those who might be widowed, those who might be returning from military service, those who may have lost a child, those who have suffered from various levels of abuse or neglect. Finding groups can sometimes be really helpful. If you can find a community or individuals who have been through something similar, sometimes that camaraderie or familiarity breeds an environment where someone can start to feel better, grow, and heal. And I think that that's a big factor. This conversation for us is very much not medication related. So it's kind of cool for us to talk about because it is a little bit more therapy based. And I like the fact that you can put these two modalities together and theoretically get these symptoms that happened to a client more under control. I like that thought.
Yeah. Same here.